Adaptive hybrid surgery is a concept that stems from this multidisciplinary need to manage these tumors. And it allows the practicing neurosurgeon to get a very detailed radiation therapy input in real time during the course of surgery while debulking the tumor.
We sit down and pre-plan a surgical approach on the day before the operation. This is where we can discuss what the ideal sculpting of the tumor would be to make an ideal radiosurgical target. And this is very important to do this pre-surgical planning. You can get this information on the fly while you're operating, but having a target becomes important because while you're evaluating, you're really heading towards a target. And also in your pre-surgical planning, you're thinking about what do you need to do.
So then the patient goes into the operating room where the actual debulking is done. And it's, many of you probably have some form of cranial navigation. So this particular system involves the BrainLab cranial navigation system, and it is able to recalculate the radiation therapy plan in the OR in real time based on the actual extent of resection that's done. The assessment is done intraoperatively at certain intervals. And after the debulking is completed, then the patient goes to the recovery area and can be treated with postoperative radiosurgery treatment the day after or several days later, and really not with a prolonged fractionated treatment, but with a single session treatment. So you really can reduce the treatment time quite a bit.
In the past, we might even be able to identify our ideal resection, but we weren't able to check it on the fly as we go and get validated outcomes for the quality of our radiosurgical target. Now, with this new software, we can actually get a real-time assessment of how well the resection matches our ideal plan and how good of a radiosurgical target we have to allow us to decide when enough is enough and we can stop operating. The value of this is that we find that we would stop sooner than we normally would if we were operating by conventional judgment, and hopefully reduce morbidity in the process.
As you can imagine, presenting the operating neurosurgeon with a wealth of radiotherapy or information can be quite overwhelming. The way the system is set up, you have two screens. You have a surgical screen and you have a radiosurgical screen, and we summarize the radiation therapy data. But the bottom line is this is the preoperative tumor volume, the planned subtotal resection volume. You can see what those contours look like. There are three columns, as you see here. The first one is for conventional treatment, which should be able to treat essentially all tumors, irrespective of size, shape, or proximity to other critical structures. Then there's a 5-fraction radiosurgery treatment option, which is the second column here, and the single-fraction radiosurgical treatment is calculated as the last column. So in the first case, you can see this tumor is simply too large to enable safe single-session radiosurgical treatment, so that option is not even presented to the neurosurgeon in the OR. And then the conventional treatment is possible, but is associated with significant morbidity, and so is the 5-session treatment. Can they be done? Yes, but it's not an optimal treatment approach. So the idea is that if you can actually achieve the subtotal resection you plan, you can convert a patient from not being able to have this single-session radiosurgery treatment to then being able to have a very safe post-operative treatment that's done in one day. The way we summarize the radiation therapy dose in the OR is we really use the traffic light concept. So the larger circle here demonstrates the effective tumor coverage, and that's really defined as 100% of the dose being received by 97 to 99% of the tumor volume, and there are some conformality index parameters that we use, and we similarly define the marginally effective and then essentially what's unacceptable tumor coverage from the radiation point of view. So we have a smaller circle that displays the maximal dose to the organ at risk in question. So in this particular case, you have the mean organ at risk dose that's safe, but then the maximal point dose is unacceptably high. In other words, can lead to potential injury. In this second case, you have a mean organ at risk dose that's unsafe, but the maximal point dose seems to be within parameters. And lastly, this is a very interesting scenario where the maximal organ at risk dose is acceptable, but we chose to essentially ignore the mean dose, and this can be done in cases, for example, when somebody has a functional hearing loss and you really don't need to pay attention to that particular parameter. Here's a quick visual summary. You can see that we summarize all of these organ risk parameters very easily for conventional treatment, 5-session treatment, and single-session treatment. And then if you click on it with a simple touchscreen, you can actually get an expanded view which can show you which parameters are problematic, so those can be addressed. And the tumor can be actually sculpted to make it an ideal radiosurgery target.
Historically, the goal has always been to take out as much tumor as possible. A more pragmatic and I think a more thoughtful approach is to recognize that taking out all of the tumor can cause problems for the patient, and that leaving a little bit of tumor behind may facilitate management with other modalities, including radiosurgery.
I believe that the multimodality approach to complex skull-based tumors is the new standard of care. It allows functional preservation while maintaining very high local control rates for these benign yet fairly morbid tumors. I believe that adaptive hybrid surgery allows us to standardize this treatment approach and to introduce more objective metrics for achieving optimal outcomes.
We've made assessments intuitively in the operating room about what we could leave behind and then treat with radiation. There's a real need for an objective assessment in real time in the operating room to facilitate an understanding of what type of radiosurgery target are we leaving behind and how good a radiosurgery target is it, given the potential toxicities to the tissue around it. And that, in essence, is the concept of adaptive hybrid surgery and what this technology offers us.